We are live.
Okay. So, a very good evening to all of you. I am Dr. Abhijit Kumar from Zydus Healthcare Limited. First of all, I would like to welcome you all in this presentation on Bempedoic Acid in Uncontrolled LDLc, Unlocking Concept and Unleash Efficacy. For this, we have our respected speaker, Dr. Rahoul D. Sawant sir. He is MBBS, MD, MRCP, CCT in Cardiology UK, International Fellowship, Mount Sinai Hospital, New York, USA, Assistant Professor of Cardiology at Bharti Hospital and Bhartiya Vidyapeeth's Medical College, Pune, Head of the Department Cardiology and Director of Cath Lab, Mobile Hospital, Hadapsar, Pune, and CEO of Hriday Mitra Cardiac Clinic, Pune. So with this, I would like to welcome our esteemed speaker, Dr. Rahul sir, once again on board. And without wasting much time, I would request sir to please take over the scientific agenda.
Thank you so much, Dr. Kumar, for introducing me. I hope I am audible and clear.
Yes, sir.
Thank you. So, obviously, we will start with the presentation straight away. Okay, can you let me know if you can see the slide, okay?
Yes, sir. Okay. Yes, sir. Slides are visible.
Okay, thanks. Okay, so it's a full screen, right?
Yes, sir. Full screen.
Thank you. So now, thank you so much for bringing up this great topic about bempedoic acid. We all are using statins for a very long time now, and still we have patients who do not actually get controlled despite being on maximum tolerated dose of a statin. And there's unmet need of controlling their LDL in this era where lower is the better. So you know that there is no target as such. So lower the LDL, better it is for the patients with acute coronary syndrome, cardiovascular disease, cerebrovascular disease. And that's why we have a new molecule on the block in India. This molecule has been available in United States for some time now by a different brand name. Now it's available in India. It's called bempedoic acid. If you have ever heard of this before, I don't know, but now this is the time for you to know about bempedoic acid. Dyslipidemia is always a major concern for cardiovascular event. And as you know, that number of risk factors increase, the risk of cardiovascular event increases. So you have smoking, lack of exercise, alcohol, hypertension, diabetes, and out of all these, lipids are the major contributory factor for cardiovascular disease. There have been a lot of trials on statins for primary prevention as well as secondary prevention. So these are the quite prominent trials you may have heard of: APCAPS, ALAT lipid lowering arm, ASCOT lipid lowering arm, CARDS, MEGA, Jupiter. These are the various trials we had on various statins, and which proved beyond doubt that reducing the cholesterol by a significant number, as you can see, the follow-up period has been quite a reasonable period, varying from 3 to 7 years here. And there's been around, I would say, 25 to 30% reduction in MACE events by use of statins. And it's proven beyond doubt that statins are the most important part of treatment in our cardiovascular patients. Same with the CVD in secondary prevention trials. Some of the great names you must have heard of the trial: 4S, Lipid, Miracle, Prove It, TME22, TNT Ideal, and again, different statins have been used: Simvastatin, Fluvastatin, Atova, and Prava. All these trials also showed that there's around 30-35% reduction in the event rate, cardiovascular event rate, by using a secondary prevention strategy. Okay, this is the percent change in LDL, which is, as you can see, right from 10% to 50% reduction in LDL has been seen. Obviously, these are dose dependent reductions. If you increase the dose by 10 or 20 mg, there's a rule of 10 and 6% reduction. So every 10 mg rise, you'll have a 6% reduction in the dose of in the LDL level. And there's a significant risk reduction, as I said, 20 to 30% risk reduction is seen by use of these drugs. Management of dyslipidemia is high on priority, and statins are first line therapy. Statins are being first line therapy. Statins will remain first line therapy. So the question is, do all statin users achieve LDL goal as per the recommended guidelines? And concern 2, how to achieve LDL target after maximally tolerated dose of statin is achieved. So, do all statin users achieve LDL goal as per guidelines? Answer is no. What we know is lower the LDL, better it is. So these are various trials, of different molecules, and as you can see that on this side you have PCSK9 inhibitors, Fourier trial, Odyssey trial, and there you have significant reduction in LDL level, as against you have statins where you have a moderate reduction in LDL level. And the other agents where there's a small reduction is ezetimibe. By itself, we do not use ezetimibe. We use ezetimibe always in combination with statins. Especially when the patient is intolerant to statin, we will use ezetimibe. There are in trials on fibrates as well, niacin, CETP inhibitors. We don't have them because there's a lot of problems with CETP inhibitors. So CETP inhibitors, none of them are being used now. And you have bile acid sequestration. So there are a lot of drugs available. Standard drug which is being used is statin. And you must have seen use of ezetimibe going up over last 2 to 3 years. That's because combination of ezetimibe and statin is helpful in further reducing the dose, the level of LDL. PCSK9 inhibitors are the best in the class, but they're very expensive. The cost of the therapy is around 40,000 rupees per month, and that comes to around 5 lakh rupees per year, and that's continued therapy. It's not like one-off treatment. So there's a lot of work going on in this area of LDL, and you see new molecules coming in future also. So what are the guidelines saying? What is the target? In 2016, European Society of Cardiology recommended these targets: low risk, moderate risk, high risk, and very high risk. All our cardiac patients who had a coronary angioplasty or event, their target was less than 70. And now these targets have been reduced to less than 55 or very high risk. You may wonder why. The answer is very simple. The lower the LDL you get, the lesser the events you get. That's why we're trying to get as low as possible. These are the categories of patient: low, moderate, high risk. We'll go through that in the further slides. And the targets are as per the risk of the patient. So the key is reduce the LDL. How many patients do they get to the target level? So this is the EU-wide cross-sectional observational study of lipid-modifying therapy used in secondary and primary care, labeled as Da Vinci study, and looked at 18 countries across the Europe, looked at around 5,800 patients for total reduction. So out of them, primary were 3,000, secondary were again around close to 3,000. And they're assessing what is the impact of the guidelines and whether people are really, getting to the targets. And the answer is here. As you can see, overall, only 27% eligible patients are receiving high intensity statin. So around 73% are not receiving high intensity statin. So these are the patients who should actually have high intensity statin. But physicians, cardiologists are not giving high intensity statin because I think they have their own reservations about giving high intensity statin. Okay, 33% achieved lipid goals with high intensity statin. So only those who got the high intensity statin, only 1 in 3 achieved lipid goals. So even if you give the drug, only 1 in 3 is getting, and otherwise people are not giving the drug. So that's kind of very bad. So we have guidelines, we have medicines, but people are not getting the drug. People are not achieving the target. So they looked at the statin usage in very high severity risk patients. Only 37.5% eligible patients are receiving high intensity statin. So they divided. And so actually let us see how much cardiologists are doing and how much aggressive they are in reducing the LDL. And to our surprise, only 37% eligible patients are receiving high intensity statin. And 18% achieved lipid goal with high intensity statin. So despite giving high intensity statin, these patients are not achieving the target. So that means we are lagging behind. Okay, and despite having the statin therapy, we're not achieving the goal. So we need some other medicine to bring the statins, LDL further down. What is the clinical benefit on attaining LDL-C levels as per the target? So this is the target low density lipoprotein cholesterol and secondary prevention for patients with AMI. It is a Korean study, South Korean nationwide cohort study. So they looked at around 5,000 patients with prior history of MI. LDLC achievers definition. So patients who achieved more than 50% reduction from the index event. And second was LDL level less than 70 milligram per cent at follow. Study endpoint was 2 years MACE, including cardiovascular mortality, recurrent MI, ischemic stroke, and median follow-up was 2.1 years. So results, 94% patients were on moderate to high intensity statin. So Koreans did better. And again, LDLC achievers were only 22%. So that achieved the relative risk reduction of about 37%. So in conclusion, patients with acute MI achieving target LDL level was associated with lower incidence and reduced hazard of recurrent clinical events. So whichever patient achieved the target, they got lower event rates. That's about relative risk reduction is about 37%. So obviously it's not a surprise. We know that achieving lower levels of LDL is going to be beneficial. So results, primary endpoint according to the achievement of target LDL-C goals. MACE events, if you look at this a graph over a period of 3 years. So if you have LDL less than 70 and more than 50% reduction, your incidence rate is only 2.3% against those patients where LDL is more than 70 and reduction is less than 50. So this 4%. 4% your event rate has reduced. Okay, so a significant gap as you can see from this graph. So the idea behind reducing LDL is perfectly shown in this graph. Management of dyslipidemia is high on priority and statins are first line agent. That has been bombarded on physicians. Still they are not acting, which I think they should. And obviously the second worry is despite high intensity statins, we're not achieving the target. So many times people reduce the dose just because the physician feels unhappy or the patient feels unhappy in having a high dose statin. They want to reduce the doses, which should not be the case. So what are the non-statins which are achieving LDL reductions? So PCSK9 inhibitors, so 60% reduction with PCSK9 inhibitor. So if you combine PCSK9 with high intensity statin, you're getting 75% reduction. And PCSK9 inhibitor plus high intensity statin, plus ezetimibe, you are achieving 85% reduction. So ideally, this is what everybody should get, and then people are likely to become, immortal. They will not die. I'm sure most of the population will reach a, towards 100 goal. And the current problem is PCSK9 is very, very expensive. And I think that will become cheaper eventually, as all drugs do. So we will look at reducing the LDL significantly when PCSK9 inhibitors is available. But in the meantime, what have we got? High intensity statin plus ezetimibe, and that you can achieve up to 65% reduction in LDL. So we have a new drug called Bempedoic acid. This is a first-in-class lipid-lowering agent for this class. How does it work? It works on this ACL enzyme. As you know, statins work on HMG coenzyme A reductase inhibitor. So it works on that enzyme, HMG coenzyme A. This drug works on ATP citrate lyase, ACL. So where does ACL come in this pathway? So ACL is, here is the HMG enzyme in the liver. This cycle of metabolism is taking place in liver, and ACL, as the citrate is converted by ACL into the enzyme ACL, will convert it into the cholesterol. This ACL enzyme inhibition is a stage prior to HMG coenzyme A reductase. So this is where the statins act, and a step above ACL acts. So ACL inhibitor acts on this pathway. And it's the same pathway. So if you block the pathway twice by inhibiting ACL and HMG coenzyme A, then your cholesterol synthesis is going to reduce significantly. And that is going to increase LDL receptors, and then that's going to decrease the blood LDL. Okay. And bempedoic acid also acts on ACL, which is present in the kidney, and that's why it increases the amount of uric acid. So we'll come to that. So it's present in the kidney, and that's why uric acid level will go up, and patients are likely to have gout, which is actually a theoretical discussion. Not that many people had gout when they used ACL. So management of patients receiving bempedoic acid therapy. So half-life of the drug is 21 hours. So the drug gets eliminated, after 21 hours of half-life. So that means it's going to take more than 1.5 days or so for it to get eliminated. So it's a once-a-day drug. So total excretion happens, 70% excretion happens through the kidneys, 5% through feces, and 2% is excretion is unchanged through kidney. So majority of excretion is happening through kidney. So obviously, whenever somebody has end-stage renal disease, the drug is not studied. If it's a mild, moderate, there is no dose adjustment is required. Okay. Hepatic impairment, again, though no dose adjustment is studied required, but in a severe hepatic impairment, child class C, you don't need to give this drug. So severe kidney failure, severe hepatic failure, avoid the drug. So as you know, severe kidney failure, we can give statins, but we will not give this drug. And severe hepatic impairment, we do not give statins as well. We have to monitor serum uric acid level. We have to check the history of gout, and then be vigilant if patient already had a history of gout. Patients more than 60 years of age are taking steroids or fluoroquinolones with renal failure and history of tendon rupture. We have to be careful. because there's a potential for tendon rupture along with this drug. I think this has been a concern for other lipid lowering drugs as well. And the reason for that is tendons have some cholesterol. I think tendons may become weak if you give lipid lowering drug. But actually, we don't see so much of tendon rupture with these drugs. The drug is not recommended in pregnancy, not recommended if the woman is breastfeeding. Okay, taking simvastatin dose or pravastatin dose more than 40, avoid concomitant use of bempedoic acid. Okay, as you know, we are not using simva or prava anymore here in India. We are predominantly using atorvastatin or rosuvastatin. So these are some concerns and cautions. So there is a program for this drug, which is called CLEAR program. And this CLEAR group of trials has shown that this drug is a useful drug in reducing LDL. So CLEAR program, there are different programs here. You can see CLEAR Wisdom and CLEAR Harmony. It was for maximally tolerated statin background therapy. And this is the CLEAR Tranquility and CLEAR Serenity. They are for low, very low or no statin background therapy. So these are the different classes of patients where bempedoic acid was used. And quite a lot of patients, as you can see, and the trial went on for here a year. These are the short-term trials with the small numbers. This is the biggest trial here. 52 weeks, around 30% diabetics, standard group of patients we have. Okay, so CLEAR Harmony and CLEAR Wisdom will just give you a comparison. Both groups, the patients were on statins, although here they're 90%, and they looked at overall safety of the drug and how much is the LDL reduction at the end of 12 weeks. And there's a 18% reduction in LDL cholesterol, starting very quickly, very soon. Look at this graph here. For the 4 weeks, you're having LDL reduction, and that's around 18%. Okay, so this is with the placebo, and this is with the bempedoic acid. So if you look at the total cholesterol reduction, is around 11%, but we'll not go through all that. We'll just look at the LDL. 18% reduction of LDL seen with CLEAR Harmony at the end of 52 weeks. So this difference is maintained, continued until the end of 52 weeks. So this reduction is not short-lived; it continues. It has also reduction on ApoB. 9.3% reduction is seen with bempedoic acid. Significant level of reduction. So CLEAR Tranquility and CLEAR Serenity trials, the numbers are small, but these are the patients with hypercholesterolemia and statin intolerance. So bempedoic acid was added to ezetimibe, and CLEAR Serenity patients with hypercholesterolemia and statin intolerance. Okay, so you can see that if you add a bempedoic acid to ezetimibe, there is a 32% reduction in LDL level. Okay, and if you look at the only bempedoic acid, there's 18% reduction. So that's only with the bempedoic acid and bempedoic acid plus ezetimibe. So these are the short trials showing that the drug works, is safe, and it is consistently causing reduction in the LDL level. Okay. So this is the 28% reduction. I think they're just a gimmick. They've added this 5%, but overall, you're looking at something like 18% to 20% reduction in LDL with bempedoic acid at the end of 12 weeks. Okay, and 23% reduction with bempedoic acid at the end of 12 weeks. So we're getting a reasonably good amount of LDL reduction only individually if the drug is used in statin intolerant patients. So there is a obviously you're going to think that can we use a combination of bempedoic acid and ezetimibe? Certainly we can, and you can see that there's a significant reduction we use of bempedoic acid and ezetimibe together. So when your patient cannot tolerate the statin, use these two drugs. That is going to achieve significant reduction. But the drug issue is these are the clear trials. Clear trials are not outcome trials. They are showing reduction in LDL and total cholesterol and ApoB, but they are not yet shown MACE event reduction. So this is the clear outcome study which is ongoing, which is a cardiovascular outcome trial, around 14,000 patients in phase 3 clinical trial. The enrollment is completed, and by the end of this year, December 2022, we will know what is going to happen in terms of MACE events for these patients. Okay, so 4-component MACE, at least 803 component, 10 3-component MACE, and overall treatment will continue for at least 2 years. So we'll come to know whether this drug works in reducing the heart attacks, strokes, and major events. So does it reduce inflammatory CV risk markers? The answer is yes, it can reduce inflammatory CV markers like HSCR. I wouldn't attach too much significance to that in terms of clinical practice. It's okay as a research tool. So this is obviously showing that HSCRP is reduced by use of bempedoic acid. So pooled analysis of 4 phase 3 pivotal trials. And it's a pooled analysis. So you got the numbers together. And what you can see is the bempedoic acid, there's a very slight increase in the incidence of gout and hyperuricemia. There's no significant increase in terms of liver enzymes, tendon rupture, anemia, new onset or worsening of diabetes. So it's pretty safe drug. The thing you have to look for gout. So in summary, uncontrolled LDL is a major risk factor for CVD. Statins are the first choice of therapy for any type of dyslipidemia. Even after use of high intensity statins, 70% patients have uncontrolled LDL, which we've seen in so many trials. And this uncontrolled LDL, we need to be aggressive and reduce it. So bempedoic acid is one of the classes apart from ezetimibe. So you can use a bempedoic acid to reduce LDL and total cholesterol. So significant reduction of up to 18% from baseline as an adjunct to statin, it was 28, as an 18% as an adjunct to statin. So that was the rule of bempedoic acid. And for statin intolerant patient, you are seeing around 28%. I'm not sure about 28%, I would say around 20-25% reduction in these group of patients. It is safe to use in mild to moderate CKD patient. Obviously, if it's CKD patient, uric acid also will rise, and you can have a risk of gout. So that was my last slide. I'll stop sharing slides, and I'd like to take questions if you have any.
So, thank you, sir, for this elaborative session. And now we'll move on to our question session. We have few questions also. So, the first question is, how suitable will be bempedoic acid for Indian population when statin is the first choice for Indian dyslipidemias?
As I said already, that statin remains the cornerstone. So you cannot stop statin. So you have to use statin for all the patients. Okay. Second thing is, this is an add-on therapy. So you can use it on top of the statin. Sometimes people give an example. Let's say we use atorvastatin 80 and patient cannot use atorvastatin because patient is intolerant. Okay, and you were, let's presume you are achieving at atorvastatin 80 mg was achieving your target LDL. But then because the patient is intolerant, you want to reduce the dose and see patient is okay with 40 mg. And now you reduce the dose to 40 mg and now patient is okay. He's not having any muscle pains or joint pains and control it. But now LDL will go up because you have reduced the dose. And this is the perfect setting where you can use bempedoic acid. So you will add on bempedoic acid. So statin, this is not a substitute for statin. That's very important to know.
So, like, sir, since we have to monitor the patients for uric acid level if we prescribe bempedoic acid, so after what duration should we assess the uric acid level of the patient once we start bempedoic acid?
I think at the baseline, I would check uric acid level to know what the uric acid level is. You may know that these are the patients, usually they may have their high uric acid anyways, because they are diabetic, hypertensive, on diuretic, and CVD patients with CVD drugs, they may have high uric acid. So that's number one, you should know your baseline uric acid level. Number two, I would check there's no defined criteria, but I would go by clinical judgment. If they get gout, obviously I would check it. And number two, at the end of 3 months, I would like to check their uric acid again. I would not check it every month, at the end of 3 months. I've been part of this trial with bempedoic acid. I have treated 18 patients with bempedoic acid so far. And this trial was done over last I would say 9 months. So I have got 9 months experience of using bempedoic acid here in India as a part of a trial. And none of my patients got a gout. So just to give you an idea, don't get too much worried about gout. So the percentage, as you saw in the slides, is very minuscule. Let's say maybe 1% or less than 1%.
Yes.
So you'll not be worrying too much about gout. It's something you have to remember.
So, sir, and the next question is this bempedoic acid mentioned in any guidelines as an add-on therapy to statins?
That's a very good question. Bempedoic acid is not included in any of the guidelines as of today. Okay. See, guidelines, it will come into the guidelines when there are more trials. So this trial, which ends at the end of this year, clear outcomes trial, that will give us an idea whether it would be included into the guidelines or not. See, guidelines require data, and at the moment, there's a data, but it's not adequate enough for it to go into the guidelines.
So, like, can it be combined with PCSK9 inhibitors as well as or ezetimibe, and what would be the expected results?
So my slide show that, you remember that slide I discussed, showed that PCSK9 plus ezetimibe plus statin and everything you give, you're almost getting 85% reduction of your LDL.
So, one last question we'll take. The question is, in long run, is there any chances that this could be the first line of treatment for dyslipidemia as compared to statins?
It will never be first line of therapy. Okay, you have to remember that. As far as what we have seen for last, I would say 25 years, I've been using statins for now, I must say 25 years. And last 25 years, statin has remained cornerstone. So I don't think statin will be replaced unless some really new blockbuster drug comes. Okay, PCSK9 inhibitors are a blockbuster drug. They're very expensive, and I don't see them coming down to us for next 5 to 10 years. Yes. For sure. So as a general population, what we have statin followed by ezetimibe and bempedoic acid. See, ezetimibe has been included in the guidelines, okay, but it is add-on therapy. It is not a first line. First line therapy will always be statin, and these two drugs will be always add-on.
So thank you, sir, once again. And now we have come to end of our today's session. First of all, I would like to thank our participants for making this an interactive session, as well as for the questions and their zeal of participation. and we also see in future to conduct more such scientific activities. So for this, again, I would like to thank Dr. Rahul sir for sparing his valuable time at this point of late evening and enlightening us with this brief and very informative session. So once again, thank you, sir. Thank you once again.
Thank you so much for having me, and I thank all the audience who have been listening to this talk. Thank
And
you.
sir, currently around we have around 250 plus participants.
Wow. So there's a lot of excitement about this drug. Have they got an option of asking a question in a chat? That
No,
also.
sir. Actually, we have the different link. From there, these are their questions only.
Okay, great. Okay, thank you so much.
Thank you, sir.